Welcome, everyone, to another episode of Rare and Real. Today, we're going to dive into two respiratory conditions, bronchiectasis and NTM pulmonary disease. I'll be your host. I'm Nate Stasko, CEO of Vast Therapeutics, and we're committed to developing therapies for patients with rare respiratory diseases. Today, I'm excited to be joined by John Torrence. John is not only living with both of these, bronchiectasis and NTM, as a patient. He's willing to share his journey with our community today, but he's also on the board of the COPD Foundation, who recently, because of the size of the problem, has created the Bronchiectasis and NTM Association, among other things, to promote a large care center network for these two diseases. And so, John, I'd love for you to share your journey today, and he's going to share the impact that these nonprofit organizations can make on patient journeys as well. So, welcome to the show, John.
Thank you for having me, Nate. It's a pleasure to be here.
Well, I'd really like to start with defining for our audience what is bronchiectasis from a patient perspective.
Well, bronchiectasis is the unnatural widening or dilation of some of the airways in your lungs. Many times it's called a scarring of the lungs. And on the surface, it seems like that would give you more airspace, but because of the way it happens, it actually reduces your ability to use that airway. It reduces the net usable airway.
Gotcha. And is this something that is brought on over time or by a rare genetic mutation?
Well, some of that is still out for research. Most doctors indicate that it's a result of earlier, sometimes childhood injuries. Could be allergies and asthma, sinus issues, things that have happened over life that you didn't realize had long-term implications. In my case, as I'm sure the story will develop, it runs in my family. So my mom had this, my sister has it, my cousin had it. So there must be some of each going on.
Yeah, there could be an underlying genetic link as well. And so it's a big, hard word to produce, bronchiectasis, but what does it mean for you on a day-to-day basis? Like, how does bronchiectasis impact your quality of life?
Well, bronchiectasis is, first of all, it's a permanent condition. There's no way to get rid of it. It tends to be progressive, meaning I'll get more of it over time. The net result is it means that I am at risk for all kinds of rare infections in my lungs. So whereas I go through the same environment everyone else goes through, I may pick up infections that other people are immune to.
Got it. So it's about to be fall. The leaves are changing. There's a lot of organisms that live in the leaves and environmental pathogens that most of us don't have to think anything about. But unfortunately, you've also had to battle the rare respiratory bacteria, non-tuberculosis mycobacterial disease. And that's what NTM stands for. And from your perspective, can you tell us a little bit about NTM and what it has meant as now you've just stated, you're subject to these rare respiratory infections?
Yeah, in fact, when I had spent 2 years coughing on my own and not seeking any treatment, then spent a year seeking treatment from my local clinic. And after many visits and lots of different tests, that was what they came up with. The first thing they told me was about this NTM as a bacterial infection, and then they tell me, well, this is a bacteria that exists in the normal environment, and they said, we have no idea why it became an infection in you because you're a healthy guy, so they were kind of stumped.
Like when I go to the doctor with a respiratory infection, they give me a 7-day course of an antibiotic and it's gone. Does that work on NTM, or is there a lot more to the story than that?
Well, almost everyone in our group of patients will tell that story of, oh, I had a cough, I went to the doctor, I had pneumonia, they gave me 5-10 days of this or that medicine, it didn't work, I came back. And almost always, my patient's view is that most doctors don't know about these very rare conditions. So they're treating what they think is pneumonia with a few days. No, NTM is not treated with a few days of a simple antibiotic. It's a long, hard treatment, many times a year and a half of multiple antibiotics.
Yeah, so the standard of care is like a triple cocktail of antibiotics that all have their own side effects and their own effect on your health. Can you talk about the side effect profile of being on, you know, multi-year therapy of antibiotics? Have you been able to avoid many of those side effects, or have some of them affected you?
I've had, well, no, I live with the side effects. I've been on 16 different antibiotics
Wow.
over 13 years. I've had 4 major courses of treatment for NTM infections. Plus, I've had miscellaneous infections that have come along the way. Um, the side effects start with disturbance to your gastrointestinal system. So, because these antibiotics are eating up the good bacteria you need to digest your food. So, we do have ways of minimizing that with probiotics and timing. Um, but it takes some getting used to. Your day becomes very structured, and then there's some other long-term side effects depending on particular medicines.
Right. Um, So at this point, if we had a chance to meet several years ago, I don't know if you remember, at the American Thoracic Society meeting on the conference floor, and I was just extremely interested in your story. At that time, we had just started our non NTM development program. Um, at this point, is how many patients per year in the U.S. are affected with NTM?
Well, the number that I hear, and I don't know how true it is that there's a total of 200,000 NTM patients in the United States. I haven't, they tell me the
Numbers
population
getting
is
bigger.
growing. Yeah, well, yeah, they tell me the population is growing, but I don't know that our research has kept up with it. So compared to the United States population, it's a small number, but 200,000 people, is a lot of people to be this disturbed from their life plan that, they wanted to have.
Gotcha. Yeah, for sure. Um, and then when we met on that floor, I told you we were developing a therapy for M. abscessus, and you almost hugged me, I think it was, and because M. abscessus, you want to talk to the audience about sort of the different classifications of NTM, and while there have been
Sure.
new advances for certain ones, the particular types don't have absolutely any treatments approved on the market.
Yeah, NTM is a broad group of species. There's about 200 different species within the whole class, but only, as far as I know, about 15 are really pathogens. The most common are in a group that's called MAC, Mycobacterium avium complex, and they're the ones that are treated with that classic 3 antibiotic oral medicines.
Right.
And that's about 85% of the population. But for about 10 or 12% of us, my starter infection was abscessus. It's a significantly more durable bacteria, as I understand it, much harder to treat. So you end up with intravenous medicines as well as oral. And in my case, and very typically with abscessus, I had to have surgery to remove the upper right
Oh,
lobe of my
wow.
lung. And they said that was because of the bronchiectasis, but it was a matter of there was so much bronchiectasis, I would never be able to clear this infection. So, that sounds like real tricky stuff to me. But so, yeah, abscessus has played a major role in my life.
I'm sure you had a strong family and sort of network of support around you as you were battling M. abscessus. And so, do the physicians actually, are they honest with you and say there is no cure for this particular bacteria? I mean, do they speak that frankly to a patient who has M. abscessus?
My first infectious disease doctor, he was the smartest person I've ever met up to that moment. Of course, now I have lots of smart people around me. He was very candid, and he told me that abscessus was such a strong infection that I was going to need to take antibiotics that were as strong as the infection, and they become very toxic. And he said, essentially, you have a choice between hearing and breathing,
Oh, wow.
because the medicine I'm going to give you is going to affect your hearing. And most people find that offensive. I found it very clarifying, because he said right up front this is what's going on here. It's inconvenient to lose your hearing. I have hearing aids today because of extended use of that medicine, but it would have been catastrophic to lose my breathing.
Correct. I mean, these patients like John are making life-altering decisions to preserve the ability to breathe and function and go about their normal lives. At this point in your care, what would you say is needed the most? If you could wave a magic wand, what would you create for patients in NTM?
Well, there's two things on the global scale. I joined this foundation, and we created the Bronchiectasis and NTM Association specifically to create a care center network so that there is world-class care available. So many of us wander through what I call the medical desert for years, having doctors that are well-meaning, but they simply don't know what to do. So our goal is to find these patients and get them channeled into expert care early, before their disease advances, and get them the best education. So on a very global level, that's an incredible step. And I'll tell you, before you think I'm all selfless, I know there's a genetic connection. I have nieces and nephews. As far as I'm concerned, I need the system in place for them, because
Right.
this is personal. On a second level, my personal mantra is, we as a group of patients need more time with respiratory therapists. They're the ones who can coach us through our daily activities, our airway clearance and breathing exercise and other things. They have the expert knowledge. We're often denied the ability to have time with them to learn what we need. So I'm always out preaching, that however we do it, I don't know if it's a Medicare reimbursement issue or if it's a scheduling or a lack of understanding. I'm telling you, every patient I've ever talked to has needed more time with a respiratory therapist.
So John really highlighted the access to care as being the big gap in both the COPD Foundation's actions in creating this care center network with doctors like Kevin Winthrop and
Mm-hmm.
Dr. Patrick Flume.
Yeah.
Two of those are advisors for VAST. Um, but what we're doing at VAST is actually trying to get a new therapy in the hands of those physicians
Mm-hmm.
to get access for you. So in the future, we would aim that when you hear you're diagnosed with M. abscessus, the physician says, "Oh, have I got a new treatment for you? VAST Therapeutics just got this drug approved." That is very forward-looking, but hopefully it does not have the side effects of other antibiotics. It does not breed resistance. Those are two things about our drug that we're developing. We recently, I don't know if you saw this, John, were awarded a $2 million 2-year grant from the National Institutes of Health to focus on M. abscessus specifically. They created a sort of special notice of interest for therapies targeting M. abscessus. We were one of the lucky companies to be selected for treatment of M. abscessus, and so our program, we would look to enter the clinic in the next calendar year, and we will continue to develop it for patients like you and beyond. Um, if you could speak directly to other companies, you have one on the phone today, but we're asking, what would you say to other pharma, big pharma, small pharma, developing innovation and treatments for patients with NTM? What would you tell them you need most?
Well, we need their love and attention. For many years as a patient group, we did feel quite isolated, quite unloved, if you will. And recently, as you know, there's been several companies that have expressed interest in this space. Um, I really get the impression we've only touched the tip of the iceberg of the patient population. I think there is a whole nother group that is running around coughing, and they're accepting that definition of pneumonia from their doctors, and they're not going deeper like I did and saying, I need a better answer. We're going to find it. And the same is true in the bronchiectasis space. We find more bronchiectasis the more we look in other populations. So unfortunately, this is a growth industry. So I'm thrilled that you're entering this space, and the idea of non-toxic treatments is very welcoming to all of us.
Yeah. Well, John, would you like to share anything about how you transitioned your personal journey into the role with the COPD Foundation and some of the work you guys are doing on the advocacy side? You mentioned getting the word out, creating better care network already. How about when you've actually had a chance to talk to patients? What are you telling people that are recently diagnosed with M. abscessus? Obviously, you don't want to tell them you're going to have a piece of your lung surgically removed. But what guidance do you give to other patients as part of your mission?
Well, I'd like to not have to tell them about surgery, but unfortunately, in today's world, surgery is very common in the abscessus population, when it's appropriate, and not everybody is appropriate. Abscessus is a tough infection. And those who get it are going to be greatly affected by current treatments. And even when you clear it, and this is really frustrating for patients, when you clear the infection, you still have the bronchiectasis that creates the perfect environment to get it again. So
right.
we talk a lot about environmental changes where they might mitigate their exposure to the bacteria. We talk about doing their airway clearance, getting exercise, things to make it easier to flush it out of your system on a daily basis. And some of it is adjusting your expectations about, what your future is going to look like. This isn't the life that I had planned.
Right. Are you on any inhaled antibiotics daily, or all of them are systemic?
I'm not currently on inhaled antibiotics. I have been in the past at various times for different treatments. And I have a couple inhalers that are more systemic, just for better breathing right now.
Gotcha. So you mentioned, M. abscessus being very different from the MAC class of bacteria. And one of the things we're really excited about is that our founder, Mark Shanefish at UNC Chapel Hill, has published that nitric oxide really doesn't care whether you're MAC or you're M. abscessus. It works equally on both. And that's one of the things that's leading to the high level of enthusiasm for our approach. Well, John, it's been an extreme pleasure to interview you today on our Rare and Real interview series. If you'd like, you can watch this video on our YouTube page. And if you're not already following us on social media at Vast Therapeutics on Instagram, Facebook, or LinkedIn, please do so. We are passionate about creating innovative therapies for patients like John and addressing unmet needs, particularly those with rare respiratory conditions. If you have any other thing you'd like to share with the audience, John, now would be the time to do that.
Well, I'm just thankful that you have entered this space, and others like you. Our patient population certainly needs more innovative strategies. The idea of non-antibiotic approaches, we welcome that. And we'd be happy to work with you in the future to make sure patients are aware of what you're doing. So again, we're thankful to you.
Okay. Well, we're thankful to you. Without patients, there would be no clinical drug development. And it takes both patients, families, pharma companies, advocacy groups, everybody pushing innovative medicine ahead. That's about all the time we have today on our Rare and Real interview. Please tune in next time for more patient stories like John's. Thank you.
Thank you, Nate.